Welcome to the Enhancing Clinical Practice and Outcomes stream of SNOMED CT Expo 2021. My name is Nick Eggerhaus, and I'm the Global Vendor Engagement Lead, as well as the Customer Relations Executive for the Middle East and Africa at SNOMED International, and I'll be moderating today's session. Please use the live Q&A box in your AirTouch device to type your questions to the presenter. All questions will be answered at the conclusion of the presentation. I'm now pleased to introduce Jim Campbell from the University of Nebraska Medical Center, who will be presenting Deploying SNOMED CT in Real-Time Clinical Decision Support. Jim, please proceed.
Nick, thank you very much. And I appreciate your attendance at this session today. I want to talk to you in the next 20 minutes about how SNOMED CT can be used in real-time decision support and how we do it at Nebraska. I want to acknowledge my co-presenters, Nick Staffend and Scott Campbell of the Department of Pathology, and also Libby Pfluger, who is on our EPIC build team. Some of the work that I will be describing to you was funded by the NIH as a part of a big data research warehouse grant. To mention that without our Nebraska Medicine IT team, the Nebraska Medicine EPIC build team, and our Research Information Technology Office, none of this would be possible. Olivier Bodenreiter of the National Library of Medicine and Robert Wynn, and also Jeff Wilkie of Virginia Technical Institute were important contributors to this presentation. And I have no conflicts of interest in what I'm going to discuss. So looking back at the history of the use of SNOMED CT in decision analytics, arguably it began about 20 years ago with the appearance of ref sets, which are basically precompiled value sets, if you will, of SNOMED concepts that can be used in decision logic. Fast forward 8 or 10 years, and the hierarchies in SNOMED began to get mature enough that they could be used in order to define diagnostic and procedural concepts that could be used in decision logic. And at the time that we installed our EPIC system in 2012, those were the only features that we could really employ from SNOMED for decision analysis. Part of what I'm going to talk to you about today is that the concept model has been evolving in SNOMED CT, and it is now rich in defining and qualifying relationships that can be used in decision logic in ways that were not possible in the past. And I want to basically introduce you to some of those ideas. All of this, of course, depends upon vendor implementation of SNOMED CT now. And that's also part of my agenda today in terms of moving that forward. I want to discuss 3 use cases that we have deployed at Nebraska where decision analytics are supported by SNOMED. The first is on immunization guidelines. The second is on selection of antibiotics for treatment of infections. And the third is in laboratory test reporting. So I spent 45 years in practice as a primary care clinician. And this question came up a lot, okay, in my daily practice. Is my patient eligible for an immunization? And I'm going to discuss specifically the pneumococcal immunization profile. The Advisory Committee on Immunization Practices at the CDC basically sets the standards for how immunization should be administered in the US. And here you see the guideline, which is very, very complicated, includes lots of different agents that need to be administered, is organized by age and also diagnostic criteria, as you can see here at the top. Pneumococcal conjugate vaccine is one of the guidelines, and it was actually the first one that we deployed when we first implemented EPIC. Back at that time, arguably there were two SNOMED CT hierarchies that were well organized and had some defining features built into them. Here you see the definition in SNOMED of pneumococcal pneumonia. The computable definition is defined by two ISAs, streptococcus and pneumococcal infectious disease relationships, basically specifying that pneumococcal pneumonia is an infection that involves the lungs. It leads to inflammation and consolidation, and it's caused by strep pneumonia. And I don't think I have to convince you that these relationships basically are knowledge features which are rich sources of possible analysis for decision analytics. That's where I'm heading with this whole presentation. Back in 2012, the other was in pretty good shape at the time, and that we deployed in our decision analytics was procedures. And here you see the definition of a laparoscopic total splenectomy, which basically consists of removing the entire spleen using a laparoscope. And I think you can, a computer could use these analytic features in decision support. Now, when we implemented EPIC, the sole SNOMED CT features that they supported were basically querying the ISA hierarchies. We call those subsumption queries. One of the criteria, the pneumococcal vaccination, is that the patient is asplenic, which means there's either or surgical asplenia. In SNOMED, we basically define functional asplenia as the concepts and their children in this list that you see here: asplenia, hypoplasia of spleen, etc. And basically, using the ISA hierarchies in SNOMED, you can query SNOMED and come up with the value set, basically the ref set, if you will, of what diagnoses constitute functional asplenia. Proceeding to surgical asplenia, you can appreciate that in the procedure hierarchy. Querying splenectomy and its children basically gives you the list of all of the diagnostic of the procedural concepts that constitute a history of splenectomy. Now, deployment of the pneumococcal immunization rule in EPIC was complicated. It led to a whole set of rules that were organized by age that basically employed SNOMED CT problem list queries using the eligibility criteria, the groupers that I outlined for you previously. And for pneumococcal vaccination, there are actually 22 separate problem list queries that needed to be supported for diagnostic criteria, including asplenia, asthma, chronic heart disease, leaks of the CSF, malignancy, etc. So you can see that the decision logic for pneumococcal immunization is complicated. SNOMED basically made the job of figuring out whether the patient fits the diagnostic criteria based on their problem list a whole lot easier. Now, subsumption hierarchies, subsumption queries are basically an important feature that is useful in decision logic. But back at that time, at least, many SNOMED CT hierarchies were not well developed yet. They didn't have a well-defined concept model. But in the intervening decade, the SNOMED editorial team has been very busy, and the concept model has been evolving and expanding And SNOMED CT knowledge structures are becoming much more reliable. Arguably, those hierarchies that have had the most work in the past decade are body structures, observable entities, which I'll talk about in a second, pharmaceutical products, situations, specimens, and substances. And well, what does all that mean? Let me give you a concrete example. So the second use case that I want to discuss is what antibiotic from my hospital formulary should I use to initiate treatment for this infection showing an E. coli on rapid testing? You know, that treatment of infections is a common problem in clinical practice. And basically, the standards of care rest upon the use of something called an antibiogram. An antibiogram is a profile of bacterial organisms and their antibiotic susceptibility history, statistically assembled in such a way that it basically tells the clinician what the likelihood of susceptibility to a specific drug will be. And it's critical for making immediate antibiotic decisions as well as refining therapy. This is an example of an antibiotic we have at Nebraska. And you can see here the report, in this case from all inpatient units, of the susceptibility of E. coli to the antibiotic aztreonam. And it's historically at 90.9%. So the clinician uses these reports basically to select likely antibiotics that will be likely successful in treatment and makes real-time decisions on antibiotic selection. Now at Nebraska, we thought we could make this better. And luckily, in the US, have benefited from meaningful use in that laboratory tests are reported electronically. Given the fact that we had electronic data and that we had coded all of our results in SNOMED CT, we thought we could assemble an electronic antibiogram using the test data and employing the SNOMED CT relationship structures that I mentioned earlier in order to build our antibiogram database. And basically, some clinicians call this the bug drug report, which is basically, you know, what drugs are the bugs sensitive to. So we started off with the reports from the laboratory of the organisms that were cultured. And we have all of our results coded into the organisms hierarchy as subtypes of bacterium. And here you can see, for example, the bacterial species hierarchy for E. coli. After the report of the particular bug that is involved, we basically collate the test reports, and these are all susceptibility tests. Susceptibility is checking whether or not a particular bacterium is sensitive to a particular antibiotic. And in SNOMED CT, we have all of our laboratory tests encoded in the observable entities concept model. And so here you see, for example, the definition of the test for the aztreonam susceptibility by MIC of a bacterium. And the relationships which define this particular concept as specified by the Observables concept model, basically identify this as a susceptibility test, that it's about a bacterium, and importantly, it points to the antibiotic that is being tested in this particular test, namely aztreonam. So I think you can appreciate that this is a relationship which basically links the test report to the antibiotic that we may want to select. Now, these test reports are collated into a database of antibiogram facts, which you see here. And so, for example, in a database, a test positive for E. coli that has been tested against the drug aztreonam is reported as susceptible, okay, in SNOMED CT. This particular test happened to be done on a venous blood specimen so that the clinician can basically query by the types of tests, or I should say what is being tested, as well as where the test was, or where the specimen was actually obtained. All of these are important to the epidemiology, if you will, of building that antibiogram for the clinician use. Finally, got the susceptibility report in the antibiogram, and we want to link formulary. Well, all of our orderable medications in Nebraska are basically encoded with a SNOMED CT medicinal product model. So you can see here aztreonam 1,000 milligram injection, which happens to be a drug on our formulary. We know from the concept model that it is a 1,000 milligram per vial product. It's basically an injectable, so it's suitable for IV use. And it contains the active ingredient aztreonam. So these relationships in the product basically link it back via a decision analytic process to our susceptibility reports so that the clinician can basically be assisted in selecting his antibiotic. Now, at Nebraska, when we deployed the antibiogram, we years of clinical history from our laboratory and validated our antibiogram against the historical publications by our infectious disease specialists. Currently, we're processing 1,000 or more susceptibility reports a year for 20 healthcare institutions in Nebraska, and we're reporting those antibiograms for real-time clinical use at these institutions. Our antibiogram basically is far superior, if you will, to the historical product because since it's electronic, ad hoc queries can support real queries to answer questions that were not possible in the products that such as what's the susceptibility of staphylococcal species in an ICU specimen that was drawn as a blood specimen, or what's the susceptibility pattern for amikacin-resistant E. coli in a urine culture that came in from clinic. Those are examples of questions that can be answered real time using the decision analytic approach and SNOMED CT. Finally, I want to make a few comments about the use of the clinical laboratory. For that, I want to mention a use case that we discussed recently with our emergency department who wanted a screen for opioid use because there's a readily available antidote called naloxone if a patient has an opioid overdose, and they'd like to know if this patient has ever been demonstrated to have used opioids. Now, that sounds like a simple question. Just go to the electronic record and take a look and see if there's a test there. Well, the problem is that in the US, there are 122 separate substances, either street drugs or prescribables, that are actually opioid active, okay? And in the US, laboratory testing scenario, there are 262 discrete laboratory tests that basically report those results. So I think you can appreciate why our emergency physicians were asking for a report that basically summarized this data in a quick and easy form, because they were never sure whether they had actually identified all of the tests of significance. So this is an example of where the substance hierarchy, which has developments that basically point to the physiologic actions of common medicinal substances, and the observable entities hierarchy, where we have coded all of our laboratory tests, can come into play, because the query for a test which has checked for the presence of an opioid receptor agonist in either blood or urine is a simple matter to write, okay? And here you see, I have basically done this in Protege for demonstration purposes. And listed below are the various, the 262 different tests that basically constitute an opioid screen. And I think you can appreciate from this list that a simple keyword search would not give you your list of laboratory tests in a reliable and useful way. Now, I bring this up because worldwide laboratory testing are in common everyday use, both clinically, in clinical research, and in public health. And I just wanted to demonstrate that the deployment of SNOMED CT is as metadata in our electronic health record systems provide very, very useful information, such as, in this case, what a particular laboratory test result actually means. And those results can be computably used in decision analytic use cases in ways that would otherwise be very, very difficult. So that concludes my presentation, and I thank you for your attention, and I welcome your questions.
Thank you, Jim, for your presentation. Can I ask that attendees give us a moment while we switch over from our pre-recorded content so that Jim can address the questions you've been submitting live? Please also note that this session will be available on the event platform for the next 3 months. Thank you, Jim, for that excellent presentation. We have a couple of questions coming in at this point, so maybe we'll just kick off with that. So the first question was, fabulous work, and it's amazing to see the power of SNOMED CT being leveraged. Are you having to do any queries that need ECL and or DL, and then brackets real-time classifier, to answer any day-to-day queries, or do you just precompile or fully model everything you need?
Is that Jay Cola that asked?
It is, yes.
Yeah, Jay, we are doing real-time queries all the time, both for demonstration purposes and also to solve questions, especially coming out of our laboratory. You know, the implementation of the observables concept model was somewhat labor intensive at first, but frankly, it has really paid off from the standpoint of the ability to manage our lab environment much better than we ever have before. And right now, we're actually in the midst of a project with the Food and Drug Administration, where we're looking at the ontologic model to basically promote interoperability of lab tests. So I think it's a big deal.
Thanks so much. Second question from Sarah Warren. Great presentation. What use cases would you like to see clinical decision support being used in next?
Sarah, that's a question that seems to have a room full of answers in my head anyway. I guess speaking as a clinician, I think that we should prioritize our needs, on outcomes for the patient. And I suspect that basically those use cases differ a little bit between institutions. I think that one of the goals of this presentation was to make decision makers, administrative decision makers, aware that SNOMED CT is not just a terminology. It's not just a set of codes. It's basically a knowledge base that we need to start deploying and using effectively. And so I think I would bounce your question back to you and reflect that I think that depends entirely on where the clinical problems lie at your institution. And if that's avoiding an answer, I'm sorry, but I think that's what I believe.
Thanks, Jim. Just one more question quickly from Michael Kemna. Great presentation, excellent work with real-world application. How do you foresee the future with regards to development of these CDS services? I think it's a bit similar to the previous question. Some features you show are clearly falling under the medical devices category, but some queries would in the future also be possible for doctors to create on the fly.
Well, Michael, I think not only on the fly, but embedded in our electronic health record. In Nebraska, we have an informatics group that is regularly vetting the decision support use cases that we are deploying. And I think that, part of my goal for this presentation was to get vendors off the dime and begin to use the knowledge base in SNOMED CT effectively, embed it in their tooling so that institutional resources like our decision support team can basically employ the power of SNOMED in decision analytics.
Thanks, Jim. Actually, we have another question came in. I think we have time to answer. How did you overcome limitations of an EPR functionality, and how can it implement SNOMED CT and using the knowledge base of SNOMED CT?
Who was that from?
That's Kath Priest.
I'm not sure what you mean by ETR.
EPR, I'm assuming that's electronic patient record.
Okay. Could you repeat the question, please?
Sure. How did you overcome limitations of an EPR functionality, and how it can implement SNOMED CT use the knowledge base of SNOMED CT? So essentially, how did you overcome any of Epic's failings to be able to implement SNOMED CT from an analytics and decision support perspective?
Well, I think it's fair to say that we didn't overcome. I think that one of the points I made in my presentation was that in 2012, when we implemented Epic, they actually did expose some rudimentary, by that I mean the subsumption query functionality using SNOMED that was not available in our previous electronic health record. I'm sorry?
Just about done, Jim. We've got 20 seconds.
Okay. And so I would like to see Epic go further, but I think that this is really a dialogue with our vendors, if you will, that we need to undertake.
Thanks so much, everyone. Wow, took it to the